Chris, we're good to go?
Yes, all set.
All right. Good morning, everyone. And it is my distinct honor and privilege to welcome you all to the 7th Annual Jesse Jupiter International Forum, which is being brought to you by the Hand Surgery Service at the Massachusetts General Hospital in Boston. As you know, Dr. Jupiter really needs no introduction, but he is the Emeritus Professor of Orthopedic Surgery here at HMS. He's also been the past president of the ASES and the American Association of Hand Surgeons. Dr. Jupiter's career started way back in 1975 with his residency at MGH, and then he came back on staff at the MGH in 1981. If we were to make a list of all his achievements, I think we'd need a separate webinar, but in brief, he has written more than 220 original papers, 140 analytical reviews, 115 chapters, more than 1,000 presentations, and is the author or co-author of 10 texts. He has been on staff at the MGH in active clinical practice until 2020, when he retired from clinical practice, and now he enjoys golf and skiing in his spare time. The session for today is called the Distal Radius Fest. As I like to say to all my residents and fellows, that learning should be fun. And over the next 3.5 hours, this is going to be fun with Dr. Jupiter and some really spectacular faculty that we have managed to assemble. Assisting me are my co-directors, Neal Chen, who's the chief of hand surgery here at the MGH, and Kyle Eberlin from the Division of Plastic Surgery. And our spectacular national faculty include Dr. Hanel, who is professor of orthopedics at the Combined Hand Program in the University of Washington in Seattle. Dr. Hausman, who is also professor of orthopedic surgery in the Mount Sinai system in New York City. Dave Rush, a professor of orthopedic surgery at Duke, and Dr. Orbe, who's associate clinical professor down in Florida and also at the Miami Hand and Bone and Joint Institute. Our local faculty include our young guns, Rohit Garg and Abhiram Basham, who are on staff here at the MGH. And all these guys put together, we anticipate a really fun-filled next 3.5 hours. Our program will start off with Dr. Jupiter and will be bookended by Dr. Jupiter. So he starts off with distal radius fractures and ends with distal radius malunions. And in the interim, we'll be talking about bridge plating with Dr. Hanel, the volar lunate facet, which is troublesome to all of us, Dr. Orbe, scapholunate dissociation with a fracture of the distal radius with Dr. Rush, and arthroscopic management with Dr. Hausman. After each talk, there'll be cases, and we hope to get lots of questions from the audience. Zoom etiquette, as you're all aware by now, over the last 2 years, I'm sure everyone knows Zoom etiquette. All microphones have been muted and your video cameras have been turned off, but we want lots of questions from you, so please send them through the Q&A box. If we can answer them live, we will make every effort to do so. Otherwise, we will answer them online. The chat box is really meant for faculty and staff, so please don't use that. We anticipate that once this meeting has been recorded, we'll be able to send you a link to the recording 24 hours after the conclusion of this webinar. So with that being said, I will now hand off to Dr. Jupiter to take on the first talk.
Oh boy. I don't have my talk here. Let's see. Hold on a second. Can you see this?
You bet.
Okay. Well, it's a real privilege and to be here with everyone and my co-faculty at MGH. Thank you for putting this together, and my visiting scholars from throughout the country, willingness to give up their Saturday to participate in this. What I'd like to do first is go over some thoughts I've had over a long-term interest in this particular problem. This is me in 1979 when I was chief resident at the Massachusetts General Hospital. And at that time, actually, this was the treatment that we were taught. Basically, treat everything as you can with a close reduction and above elbow support. If you had a problem late with a distal radioulnar joint, you could do a Derrick. You really have trouble operating on these articular fractures because the fragments are too small. And importantly, younger patients will all do well. This was the way we treated them, with a close reduction and a sugar tongue splint that we kept on for the first 2 weeks, followed the patients carefully, and looked for hopefully a stable situation, but only considering intervention surgically after the third week or so, which made intervention obviously much more difficult. So it was not a very enthusiastic approach, and treated most in casts. What I wish I knew then was A, how to read the x-rays correctly, to understand the outcomes more clearly, recognize the difference between fracture patterns, and appreciate the indications and treatments for specific fracture types. After my residency, I went to Switzerland for a fellowship and saw a somewhat different perspective that helped me think more clearly, and followed up with my year at the Louisville Hand Center, which particularly enhanced my reevaluation, if you will, about these injuries. When I came back in 1981, as you heard, I really started to see patients who were not doing so well, who were younger, and decided to evaluate this from the experience at the Mass General. And in a few years, it turned out to be one of our residents' senior thesis and published in 1986. If you recall, in 1986, the Mets won the World Series, which was unusual, and Ronald Reagan was president, and it's when the Challenger disaster occurred. And that was me in 1986. This study was actually quite small, but it looked at patients treated at the Mass General Hospital, and in a younger age, average age 27.6. And as you see, most were treated with casts or pins and plaster. Very few had a formal open reduction. And the results were not very good. Almost 40 to 50% were not really satisfactory. And what we found was there was an obvious step off when it healed. They all developed post-traumatic arthritis. And if the articular alignment was restored, most patients were doing well. And this is one case from that paper in the JBJS, showing, as you would look at now and say, my goodness, that was not well reduced, and it had obviously carpal problems. The study was quite popular, but I didn't think it was a very good study inherently. And I convinced one of our residents a number of years later to relook at it from a more contemporary, perhaps scientific perspective. And it clearly was scientifically flawed. It was not controlled. There was no intra-observer validation. There was poor interpretation of fracture lines and no use of advanced imaging. And we underestimated the carpal malalignment. But in fact, it had an enormous impact, a huge number of citations in the index. And really, what was the reason for this? And Jody Buckwalter at Iowa made a statement that I thought was relevant. If one has the opportunity to make critical observations, develop hypotheses, and evaluate the clinical value of new scientific results, he or she can have a direct and rapid impact on medical practice. And I think that's what started to happen as people recognized the issue of the distal radius fracture. Not too long afterwards, with a close friend and colleague, Diego Fernandez, in Bern, Switzerland, we put together a book on this particular problem. Henry Mankin was my chairman, and in his foreword, he said, "At first glance at this volume, it's easy to ask, why so much about so little? After all, it's a small part of the body, and its fractures, although common, are generally not exacting a life or limb-threatening issue. Admittedly, though, it's a fracture that we often do not deal with very well." And look what happened at that same time. A number of papers in the JBJS and Journal of Hand Surgery started to swing toward operative treatment as a recognition began more clearly that these were not so simple an injury. And in the annual meetings, scientific papers and instructional courses were generally about internal fixation. And why is that? Well, it became recognized that not only is this a common injury, but it's really becoming a public health situation. And with osteoporosis being the case, it was even a more prevalent problem. In fact, if you look at this paper that was in the Journal of Bone and Joint Surgery, it recognized that the relative risk of hip fracture after Colles fractures in men was almost twice as much as in women. And it suggested that this was a risk factor for hip fractures in men. And we know that from the age-related injuries, the younger age had more complex injuries, as the older age were more fragility type fractures. Well, I wish I knew the understanding of the outcomes. And so we did a study with a nurse for her senior thesis, looking at patients treated in casts, and particularly those over the age of 65. And what we realized was that it really did impact their functional capacity while undergoing treatment and in the rehab time afterwards. We looked on their impact on function, and we found a significant difference compared to younger and middle-aged people. The older age adults had more difficulty with physical functioning, and this occurred as they healed and even if they went on to non-union. And middle-aged adults, interestingly, had more difficulty with role functioning. So anticipating the increase in the number of older age patients with wrist fractures, this became clearly an issue that people began more and more to recognize. If we look at the patients, age was not a good indicator of functional needs, and it's really the activity level had been poorly defined and not well reflected in outcome instruments. And for many people at this time, there was a complacency about patients who are elderly in terms of intervention. But we can't ignore that the number of patients that are not only living longer, but living healthier is substantial. In this study, looking at an area of California, they found that 31% of people they studied over the age of 85 considered their health excellent or good. And don't ignore the older age just on the chronicity of their age, because they'll let you know very quickly that they need to be looked at as a person. And now the definition. You know, we call these still Colles fractures and Barton's fractures. And what I wish I knew then was how to read the x-rays correctly. We didn't understand to recognize patterns that would define instability over time. And we began to recognize more clearly the relationship with articular fractures. And as Bob Medoff has shown, how to read these better, looking at separation of the in the sagittal view of the fragments, as well as the radiocarpal interview. It became obvious that x-rays, standard x-rays, would not reveal these very clearly. And we've moved toward three-dimensional scanning and computer-generated scanning to give us a much better understanding of these patterns. And what is it about the patterns? Well, newer classification systems became more practical and treatment-oriented. If you look at this classification that was in our textbook with Diego Fernandez. The interesting thing is that some of these fracture patterns were so different that the only thing they had in common was that they involved a part of the radius. We more clearly defined instability and the findings on displacement and osteoporosis and age were signs of instability as we looked at these. And this was confirmed by Margaret McQueen's group in Edinburgh, looking at the most important predictive factors: patient age, comminution, and position of the fracture on presentation. We also have begun to understand the loading patterns in the end of the radius on the column, as Bob Medoff and the group in Switzerland showed, and how the fracture patterns involve these columns that led to a more careful appreciation of how to approach these surgically. The intermediate column has been now much better understood as the loading area of the wrist. Dan Rickling in Switzerland did a unique study where he took normal volunteers under light anesthesia and instilled pressure-sensitive film, and he was able to record in vivo loading patterns, and it showed quite clearly that this ulnar-sided lunate facet and ulnar head had more forces transmitted than the scaphoid facet. The group in Austria, Pecklander's group, looked at loading in cadavers in a sequential way and filmed these and recognized that loading patterns may be influenced by stretching or tearing of the intercarpal ligaments. So they introduced a recognition that there was a soft tissue injury associated with these fractures, in some cases creating intercarpal problems. And the carpal kinematics, and we'll hear more from David Roosh about this, were very important. And we've also seen that these different fractures may or may not involve stretching of the ligaments, but not quite tearing. And this is a new area that we're kind of looking at. And the group, Tommy Lindau's group in UK, David Roosh's group, and our group have looked at these and really trying to understand that not all of these are true ligament injuries. And then lastly, the treatment. The treatment is, if you looked at how we were looking at it at the time of our textbook in 1992, went through a whole algorithmic approach involving pinning, fixators, open reduction, casts. But the problem was the bones. And we've seen osteoporosis, osteopenia continued irrespective of people's health and other conditions. So I think one of the major impacts on the treatment of fractures became the locking screw. More than anything else has changed us, the transition toward operative approach, because the anchorage in this parodic bone with regular screws was not good. There was a lot of displacement and relocation of the deformity. In order for this plate to bone work with screws, it had to create friction. And as you tighten the screws, you created friction between the plate and the bone. Well, if you couldn't do this because of inadequate bone quality, we would see a lot of loosening. And the locking screw, in essence, created an internal fixator, keeping the length and alignment a little bit more predictable. This group in Switzerland, which I was included, designed a plate that we called the pie plate, and it had a dorsal and volar component, and it involved the locking screw. And it showed pretty effectively that you can maintain the position of these difficult fractures. But the design created a fair number of tendon problems. One surgeon in Germany used this, however, to approach the volar side with this implant. And if you looked at his experience from using the standard plate and then the locking plate was quite impressive. And these angular stable fixation even in osteoporotic bone was the major advance. Putting the screws close to the subchondral bone helped maintain the situation very well. But really, the credit has to go to Jorge Orbe, who the first really showed reproducibly that the volar locking plate for dorsally displaced fractures was effective, predictable, and became what's called sustaining technology throughout the world. He's maintained his interest in this, and we'll hear from him as well in design applications and new techniques along the way. So I give him the credit for bringing this into play. And I also give the credit to Bob Medoff, because he developed not only a better understanding of the anatomy and the forces that were directed at the bone, but also in terms of the fracture patterns. And understanding this, he developed a rather simplistic way of approaching these with fragment-specific approach, identifying the fragments involved and treating them effectively. And the third individual who changed how we're doing things is Jim Beckham in Georgia. And that technique has been expanded, and we'll hear from both of these panelists about this bridging plate. So finally, I'll just briefly mention that what I didn't understand quite well in the past of the outcomes, I think we're beginning to understand this a lot better. And we, had a paper that was in Journal of Hand Surgery, and it was revisiting fractures that had failed in older age patients and by treating them operatively. And we found that these patients did very well. We used a scale that was specifically directed toward activity in the older age patient, and found that most of these patients returned to their preoperative level of activity. And these findings were consistent with standardization using this patient-rated risk evaluation in Canada. I told you that we were taught you could always do a Derrick, but we've come to realize that the distal radioulnar joint has gotten so much more stable by the volar plate because it's restored the contact pressure between the ulnar head and radius in the sigmoid notch. And so we don't see instability and problems as much as we saw in the past. But it has brought together an interest in arthroplasty at the distal radioulnar joint, as you see here. The final is osteotomy for malunions. And I'm going to stop there because that's my talk that will end this program. So this is a little bit of history up to the present, and I've enjoyed the opportunity to follow this and watch creative people develop new ideas and new treatments. Thank you very much.
That was awesome, Dr. J. That's one of the talks that I've heard it before, but I can never get tired of hearing it, just the way you describe the evolution. I think we have some cases on which we could really do with your input. And I think Neal's the lead-off hitter on this one. Neal, you're good to go?
Yes. Let me bring up my screen here. So, Dr. Jupiter, thank you very much for sharing your insights and really wonderful survey of the history of this problem. So, I want to show you this case. It's a case that that has not been operated on yet. The patient just came in the clinic on Thursday, and I think it will exemplify a lot of the principles and ideas that you were speaking about. And we wanted to get your thoughts on this case in general. So this is a 50-year-old electrician who fell 7 feet off a ladder onto his left non-dominant wrist. This is a big guy. He's about 230 pounds. He took a pretty bad fall. And Dr. Jupiter, can you give us your thoughts on we're going to walk through this case, and maybe you can give your thoughts on how you're thinking about this problem as we go step by step.
Well, obviously, the force that created this fracture was substantial. And you can see the splintering that extends from the metaphyseal area more proximally into the very distal metaphysis and proximal metaphysis, almost into the cortical region. He's got dorsal and palmar involvement. He's got this rotated lunate facet that you can see. Sometimes it may be better to get a closed reduction to keep the soft tissues out to length when he's in the emergency room, and then get a CT scan. So we really need to have a three-dimensional imaging of this.
Before we get to the CT scan, if you don't have access to a CT, do you find that traction films are helpful, or do you think that puts patients through unnecessary discomfort?
I think traction films are very helpful. With a hematoma block and sedation, it should be done pretty reasonably. It's pretty humane.
And then we spoke about splinting. Before we get to the CT, what's your preferred splint for a patient like this? Do you prefer a Charnley? Do you prefer just a volar slab, volar dorsal, sugar tongue? What should we be thinking about?
I think that Neal, this is an unstable pattern. Whether you can get a nice articular realignment with traction, it very unlikely to hold. So the idea of immobilizing with anything tight to try to keep the position is just going to look at for swelling and all sorts of problems. So frankly, a volar splint or a Charnley, so-called Charnley splint, as long as it's not too tight, and make sure that the sensibility is okay and the fingers are mobile.
So here's our CT scan, and this is going to run through all the different elements of it. And just so you can get a picture, we can run it again if you'd like. And then I took some specific slices to talk about different portions of the fracture. So here's our CT scan. And one noticeable slice is on the sagittal. We see this joint impaction and the fracture fragment rotated 90 degrees. How do you deal with this, Dr. Jupiter? This patient is clearly going to the OR. What would you do? How do you address that fragment?
Well, if we look at this, go back a ways, but I would go toward the volar side first with reduce and stabilize the volar side. I think with traction in the OR, you can manipulate that rotated fragment through the volar metaphysis. We've shown that in a series in the ICUC, and be able to deal with that. But try to stabilize the volar lunate facet and the whole volar fracture. And then dorsally, in a similar way to do an open reduction, and probably would use a bridge plate on the dorsal side.
So we can access that fragment either volarly or dorsally.
Yes.
And a bridge plate may be beneficial in trying to maintain this length. Just to mention, the ICUC is an international consortium with a collection of cases that is public, that's in the public domain. And it's a wonderful resource for exploring many of these fractures that Dr. Jupiter is involved in. And then secondly, this dorsal cortex, we can see that it's comminuted, it's very comminuted, broken into many fragments, and the entire corpus is translating. So, Dr. Jupiter, any thoughts on the ulnar side of the wrist? You had studied this at Mass General about a decade ago. What are your thoughts about the ulnar styloid fracture, and do we need to address it, and if so, what do you do to address it?
Yeah, the interesting thing about the volar plate has done is been able to restore the rotation of the radius fracture. And by doing that, hopefully the sigmoid notch can line up more appropriately to the ulnar head. If you're able to do that with your internal fixation, then, as George Orbe showed, the contact pressure between the ulnar head and sigmoid notch will keep that stable without having to deal with the styloid per se. So I think that unless there's a fracture that I'm not seeing through the ulnar head, that would be my first approach. And that's why the lunate facet, both dorsal and volar, would be very important for stability by restoring the anatomy.
We already spoke about the fixation choices. Your thoughts on other options other than bridge plating, as in fragment-specific fixation? When do you think this can be amenable to volar plate fixation only? What are your other thoughts?
Well, that's where your traction views will come into play in the operating room. You'll have to, I think, stabilize the volar side. We can see this rotated lunate facet and teardrop kind of picture, and then get a better understanding of what you're dealing with. Sometimes it's worthwhile making a capsulotomy and looking in the joint because you may find splinters in there of articular pieces. So what's dealing after that would depend on what happens in the OR.
And then just for our attendees, when you make the capsulotomy through the joint, you take a peek dorsally?
Yes.
And then finally, what's the role of carpal tunnel release? You already spoke to the ulnar side, but in certain cases, when do you release the carpal tunnel? What makes you think about other problems, soft tissue around the wrist?
Well, for me, I would think of releasing the carpal tunnel in this patient. It's pretty high energy. It's a bad skeletal injury, and it's likely to be swelling. And as our youngest colleague has shown, you could do this with an endoscope after you've fixed the fracture, right, Abhi? And I don't think, as I say, you absolutely have to fix the ulnar styloid if there's a good reduction of the joint, and that should give stability.
Well, great. Thanks, Dr. Jupiter. I'm going to open the floor.
Good luck.
Thanks very much, Neal. Kyle, you had a question for Dr. J?
Yes, Dr. Jupiter, it's great to see you, and thank you so much for your teaching today and over the years. I guess my question really was from a 30,000-foot view with the advent of the volar plate, which was a very extensive part of your career. what do you think the role is in 2022 for fragment-specific fixation, and for, how do we think through when the volar plate is enough and when we need to do something additional to that? Just globally, your thoughts on that.
Yeah, I really do think that the volar plate, obviously, if you don't have a fracture on the volar side, you don't need it. But getting back to where George Orbe showed the big impact of a volar approach to dorsally displaced fractures, proved because of the locking screw capability, a very safe approach, and one that avoided problems for the tendons and whatever's. The fragment specific is like everything else. We all should have that understanding and capability to approach things in that manner as well. I don't think it's as important on the volar side as on the dorsal side, and so I think that it has very good usefulness. When before the volar plate, we were able to do things by opening on the volar side and bringing back the lunate facet, even with a wire fixation, and then opening up the dorsal side and reducing the fractures, bone graft, pinning, and external fixator. And guess what? Those patients did very well because it was an understanding of the fracture patterns. People have gone away from external fixation for appropriate reasons. So the limited fixation on the dorsal side with the fragment specific has proven to be very good.
That's great. I think we'll move on to our next session, and it's going to be Dr. Hanel. Of interest to the audience, and our gratitude to Dr. Hanel is that he's woken up at an ungodly hour to participate in this. He's in Seattle. He's a professor of orthopedic surgery at the University of Washington. And Dr. Hanel, we are really, really grateful for your being here so early. And thank you, and we really look forward to you. Thank you. Christopher, all yours.
Hi, my name is Doug Hanel, and I have the honor of following Jesse Jupiter and discussing the emergence of dorsal bridge plating and the management of complex interarticular fractures. Although I have been involved in the development of some of these implants, I receive no royalties and have no conflicts. This technique was introduced to me at the annual meeting of the Hand Society in 1998 by Burke and Singer. And in the same year, Becton and co-workers introduced an internal fixture and reviewed their results with 35 cases. This technique has been variously named, but for the most part, the literature now refers to it as dorsal bridge plating. My first case was a patient that was involved in a rollover motor vehicle accident and sustained the injuries that you see on the left. This is her radius fracture. She has burns on her forearm and hand, and she was treated with a bridge plate. This particular plate happens to be from the mandibular reconstruction set, and it was chosen because it fit into the second compartment. Closed reduction was carried out. Pins were put across the joint. The external fixtures are holding the first web space open to assist us with burn management and burn care. She went on to heal. Her plate was removed at 110 days, and this is the functional result that she gained. Over the next 20 years, my indications have evolved into Multiply injured patients who are going to be weight-bearing on their upper extremities, extremely comminuted fractures, patients that have bilateral fractures that are comminuted, and they will need to have at least one weight-bearing extremity, and I usually will bridge the dominant extremity. Patients that are in extremis and we have limited OR time. Patients with poor bone quality, as in the elderly, and as an adjunct to a procedure that is salvaging a failed fixation or poorly performed fixation. The results of this technique are quite remarkable. Alex Lauder, when he was a resident at the University of Washington, reviewed our cohort of patients up until 2015, and he found some remarkable things. Most importantly, he found that the dominant side injuries recovered best. In a systemic review of this technique by Austin Ferris and his colleagues in the U.S. Army, there were 12 publications that could create a cohort of 302 patients. The indications were typical people using bridge plating with polytrauma and extremely comminuted distal radius fractures being the most common indication. Within this cohort of patients, they found that removal of dorsal bridge plating occurred at an average of 119 days. The significance of this is that despite that prolonged immobilization, the results match that of some of the best studies done on volar plate fixation and those fractures that could be managed with volar plate fixation alone. The complication rate for this procedure matches that of volar plating. It's 13%. The most common injury or the most common complication was hardware failure. My contribution to this systemic review was an article that appeared in the hand clinics in 2010. And of that, we had 2 broken plates and 2 broken screws. Broken implant should be treated emergently. This is the case where a delay in treatment of a broken implant resulted in rupture of all the tendons in the 4th compartment. I think that this particular implant happens to be too small to be in the 4th compartment, and if I was going to place a plate in the 4th compartment, I will use something with a larger footprint, such as a plate on your left or a forearm plate that is used on the right. Why does this fixation work so well? It is based on the premise that if this were an external fixation device and you wanted to make it stronger and stiffer, you would spread your pins out as wide as you could, and you would drop the crossbar as close to the skin as you can. Or in this case, we'd place it internally, an internal distraction device. David Rush had said that the rationale is this: an external fixture can't provide stability and immobilization of the metadiaphyseal comminution. Similarly, a volar plate cannot distract the scaphoid and lunate off of a reduced but tenuous reduction of their respective fossa. A dorsal bridge plate can. Dorsal bridge plates augment volar fixation. What's better, bridging to the 2nd or the 3rd metacarpal? Milan Stevanovich's group answered this by using the same implant on the 2nd and the 3rd metacarpal, and they found the following. They found that there was no significant difference in displacement, load to failure, stiffness, and extension. They did find that there was a 0.8 millimeter difference between 2nd and 3rd metacarpal, which they believed was statistically significant, with stiffness to flexion. I don't think that this difference translates clinically, and I continue to use this implant both in the second and the fourth compartment. This article, along with articles written by Lewis and Jason Dahl, do mention in their discussion that the fourth compartment has a higher potential for tendon injury, while the second compartment has a higher potential for injuries to the superficial branch of the radial nerve. I use a large image intensifier and 10 pounds of traction when performing this procedure. AG's reduction maneuver is longitudinal traction, ulnar deviation, palmar translation of the hand relative to the forearm, and pronation of the hand relative to the forearm. When applied with traction, such as here, you can define the personality of this fracture. And as we see here, we have volar instability and comminution of the volar ulnar corner. If the intra-articular fracture can be reduced closed using the AG maneuver, I will pin it percutaneously before applying the dorsal bridge plate. If the reduction is unsuccessful, then that's usually because the volar ulnar corner is unstable, and I will approach these with limited open reduction. I draw a so-called extended carpal tunnel release incision, as shown here, but as I've become increasingly familiar with its exposure, I usually only use that part of the incision that is marked in green. The carpal tunnel content is retracted radially. The ulnar neurovascular bundle is retracted ulnarly. The pronator quadratus is divided, and the volar ulnar corner reduced and secured. This is the volar fixation that will be augmented with a dorsal bridge plate. With longitudinal traction still applied, the bridge plate is placed on the skin and the alignment confirmed with image intensification. The proximal and distal holes are marked and will serve as the location for incisions along the radius and the second metacarpal. The dorsal radial aspect of the second metacarpal is identified along with the extensor carpi radialis longus and the extensor carpi radialis brevis tendons exiting from the second compartment. The plate will be placed between these two tendons. The proximal incision is in the vicinity of where the extensor carpi radialis longus and brevis tendons pass beneath the outcropping muscles. The ECRL is retracted radially, the ECRB is retracted ulnarly, and the plate is placed between these tendons. Many of the newer devices have handles that help you manipulate the plate as it's either passed from proximal to distal or distal to proximal. The plate will be introduced proximally or distally as directed by the displacement of the distal radius fragments. If the fragments are displaced dorsally, the plate will be inserted distal to proximal. If it is displaced volarly, the bridge plate is inserted from proximal to distal. The most distal screw is placed in first. The most proximal screw is placed in second. These are cortical screws, non-locking, and they lag the plate down to bone. How many screws, what type, and what size do you need? John Wolfe looked at the number and the type of screws and found that 3 is statistically stiffer than 2, but 4 is not statistically different than 3. Similarly, stiffness is improved with 1 locking screw, but you don't, but there's no advantage to increasing it to 2 and 3 locking screws. There hasn't been a study on the particular screw size, but the wisdom of the crowd is such that I think most of us agree that a 2.7 millimeter screw in the metacarpal is the minimum size, and a 3.2 or higher is the minimum size in a radius. In the case example that we've been following, a dorsal bridge plate was placed onto the second metacarpal, remained in place for 132 days, and the range of motion that you see was a couple of months after plate removal. This same technique can be used for salvaging poorly performed fixation. And I have to admit, I'm the surgeon that did the surgery on the left, and it is a wholly poor application of this particular technique. I removed that implant and used a different type of implant because that was available at the time, and reinforced this fixation with the dorsal bridge plate shown here. The bridge plate remained in place for 112 days, and the radiographs and clinical photos that you see are at 40 weeks post-injury. The most common use of this device continues to be in patients who have bilateral trauma. And in this example, we have a 19-year-old male who fell 26 feet onto concrete, sustaining multiple injuries and breaking his fall with his upper extremities, saved his life. We approached this by using a volar column exposure. Reduction was carried out, fixation was augmented with dorsal bridge support. Bridge plates were removed at 140 days post-injury, as ulnar and median nerves were in continuity and improving. His volar plates were removed 2 years after injury. At that time, there was complete recovery of his median and ulnar nerves. He then went on to graduate from college, and the slides on your left show the range of motion on the day that we removed his volar plates. So in summary, dorsal bridge plating is a valuable tool in the treatment of severely comminuted distal radius fractures, and the indications for me remain the same. So I'd like to thank you for the honor of being able to present today, and I'll turn the podium over to Abi Basham. Thank you.
Hey, Dr. Hanel, before Abhiram, while he's loading his slides, let me ask you this. Just going to play devil's advocate for a minute. And do you think that the ability to apply a dorsal bridge plate has empowered people to stop thinking critically of how to be more specific in fragment fixation?
Yeah, I definitely do. And I think that what I have seen and is now going to be the next indication is for bridge plating is revision of bridge plating.
That's
and
right.
People will take these and they will bring them out to length and say, well, that's as good as I can get, and that's lined up and we're fine. I think it's very, very important in these really comminuted fractures to try to get that volar column intact and rebuilt. And so I agree with you 100% that you can get pretty sloppy, and people have gotten sloppy with their reductions and their fixation.
Yes. The genie's out of the bottle, unfortunately. So.
Yeah.
All right, Abhiram, all yours.
All right. Thanks, Dr. Mudgal. Thanks, Dr. Hanel. I did my fellowship at Harborview, so a lot of this is going to seem very similar to what Dr. Hanel has already presented on some cases. But I thought we would start with a tale of two fractures, bridge plate addition. So the first case is a 50-year-old male. He has bilateral distal radius fractures. After a fall from a height, he was also on a ladder. He had a head injury, and he also had polytrauma These are the images on the right side. Just for full disclosure, his left side was mostly a volar shear pattern, which I ended up treating with a volar locking plate in buttress mode, and I won't come back to that. These are his CT scans.
Particular cardiovascular pharmacon now has grade 2 to 3 changes of about 50% surface area spotty grade.
And you can hear someone else dictating their up note in the background. Sorry about that.
The rest is including the body.
And this is his. So I thought we'd have patient 1, and then I thought we'd go through patient 2, and then we could compare and contrast and get Dr. Hanel's thoughts on differences in technique or approaches for both of them. The second is a 33-year-old male who from 30 feet to his left wrist while he was indoor rock climbing, and these are his images. And I can come back to these CT scans if we need to. So both are comminuted C-type fractures. Patient 1 has bilateral injuries in the setting of polytrauma and head injury. Patient 2 is a younger patient with a unilateral side injury. And I guess we can pause here, and Dr. Hanel, if you want to go through how you would think about each one of these, any differences in treatment for them.
Okay. Well, so, my approach to these is pretty much, I can't hear anything. There's something in the background? Okay, so I was going to say that my approach to these is I'd like better imaging. And that better imaging comes from longitudinal traction, and as Jesse had mentioned, CT scans. But we have looked at the number of CT scans that we have obtained relative to distal radius fractures, and we've been retaining less and less and less, mostly because I think that the pattern recognition is pretty much right here. And so with reduction, and especially with AG's maneuver, if that carpus just continues to translate volarly, these are people that have volar instability. The volar ulnar corner is essential, and you're going to see that in one of in the lectures to follow, is just how essential that is to have control of the volar ulnar corner. And so my start with these is, if I think that I really have to get the volar ulnar corner, if it's a small fracture fragment, then I will use that carpal tunnel exposure that I demonstrated in my lecture. If it's not, then I'll use an FCR approach, but I wouldn't hesitate then to add a dorsal buttress plate. And so, first step, figure out where you're going to make your exposure. Second step, protect your soft tissues. Third step, do a provisional fixation. Look at your fixation, and then I will look and see what kind of dorsal support I have. And in both of these cases, if I have any evidence that I don't have dorsal support, I will add an external fixer. A dorsal bridge plate, an internal fixer. But I think that we need those to be used in both of those cases. That's always available for me. And the decision, there's a couple game day decisions or in-game decisions that are made. I think that that if you looked at both of them, they both look like they're going to require some augmented fixation.
So that is what I did. So in patient one, did AG's reduction maneuver, and there was still significant volar instability. So in this patient, did an extended carpal tunnel type incision, and then fixated the volar ulnar corner with a hook plate in this case, then put a second one on the styloid because there was a shear force on that side as well. Deciding between two hooks versus using just a volar locking plate on the front. Any tips or tricks or pearls?
Well, Bob Hodgkiss has, for the longest time, has always, we've talked about cases that we're doing, and he talks about commander's intent. What was my entire goal of this operation? My entire goal was to get this, to reconstruct a sigmoid notch, to reconstruct a flexion extension arc, and to stabilize the radial styloid so that we could have stable intercarpal relationships. And so whatever implant you use to get that is the right implant, as long as you get there. And so I like these implants. I like using them in this situation. But if you said, I have a terrible time with these, then I would say, fine. Dennis takes little K-wires and we'll run it underneath the articular bone, and then we'll bend it onto the volar surface and then put a plate on top of that, which does a similar fixation as shown here. So I don't really buy into this is an implant-driven procedure, other than the fact that you have to reduce your articular surface. You have to keep that articular surface under control for the reasons that Dave Rush said, and take advantage of a bridge plate for the reasons that Dave Rush said.
So this gentleman healed in a true predictable trauma fashion. I was supposed to take out his plates 2 weeks ago, but he slept through his surgical date. So this upcoming week him out. And then, so this is the second patient. This one I took shots of the AG reduction maneuver. So the second patient, I thought his volar ulnar corner reduced very nicely just with traction and an AG reduction maneuver alone. So in this case, I solely applied a dorsal spanning plate, which nicely held the fracture.
I have to tell you, I have more and more and more have been using augmented fixation with this. And I probably would have pinned this before I put my plate on, just because it would have been my luck that I would have displaced that volar ulnar corner. And the reason that I say I fix the volar ulnar corner first is that if you fix your radial column and you malalign it, getting that volar ulnar corner in place is next to impossible. You actually have to take your fixation apart when you do that. And historically, when Diego Fernandez first described to us how he did open reduction internal fixation of distal radius fractures, he started by always using a read off of the radial styloid, and then he would go and he would reduce the volar ulnar corner and hold it in place. And when I started doing that, every time I did it, I had to take all my radial fixation out in order to get the volar ulnar corner in place. And I can remember asking him what was his trick to getting that read right. He says, I always loosen up the radial column fixation and to get that in place. And I think more and more we have just gone to making that the first move that we make. But I certainly cannot fault you for this.
So those were my two cases.
Thanks much, Abhiram.
Dr. Hanel, this is Rohit. Thank you again for the talk. I have just a few follow-up questions on the cases. When you do a dorsal bridge plating, is there something intra-op that helps you decide whether to use the second versus the third metacarpal? Is it the reduction, or is it just the way it sits in each case? How do you decide second versus the third?
Well, I can tell you there's one case that you cannot treat with plating a dorsal bridge plate in the second compartment, and that's a radial carpal dislocation. It just won't reduce. I mean, I haven't been able to do that. And so those always, with very, very distal shearing fracture, there's always a fourth compartment fixation. The other is in management of open fractures with combination. I find it a lot easier in management of open fractures to use the fourth compartment. But for the most part, my go-to is still the second compartment. You know whose opinion you should ask? Dave Rouge.
There's a panelist who asked if anyone would just use a simple external fixator for this instead of a bridge plate, which be nice to get your thoughts on too.
Well, the answer is no. Yeah. So what is the advantage of a bridge plate over an external fixator? And number one is you don't have to deal with pin track infections. The pin track infection rate of an external fixator, especially in these cases, or polytrauma cases in ICUs, is 100%. And it's usually Pseudomonas. Okay, so that's number one, no pin track infections. Number two is you can't get the fixation that is necessary. You can't control that fracture with an external fixator. You can pull it out the length, but you can't control volar tilt. You can't control interarticular displacement. So that's the reason that we stopped using external fixators. But in the same token, if you said, I can reduce this fracture, I can percutaneously pin it, I can hold those in place in my practice, and I'm really good at that, then you've succeeded. And we demonstrated that in an article that was a double-blind randomized study looking at external fixators and pins versus what turned out to be old volar implants or just implants. And we found that the answer was if you can reduce the fracture and hold the fracture, then you get a good result. And all of those studies that are now published, that's what they say. If you can figure out how to hold your fractures in place and let them heal, people do well with this particular fracture.
Hey, Dr. Hanel, I think I completely agree with you about the need for at least a temporary internal fixation, because one of the things we learned way back with external fixation was it was an augmentative tool. It was a reduction tool. It was not a definitive fixation tool. And so that's why I wonder, in this case also, I would not have been brave enough to just put a span plate. And I'm kudos to Abhi for trying it and hope it works out. But I worry about that volar ulnar corner falling off. So I'll bet you that if you repeat these films in a couple of weeks, that if it stayed there, yep.
And here's something that I do. After every fracture that I fix, whether or not I use a bridge plate or not, is I repeat my AG reduction maneuver. And if that shifts at all, even though it looks like a perfect fixation, if it has a volar shift at all, I will, I'll put a bridge plate on it.
Yeah.
Keep it from that volar translation. And in that case that I showed where I had K-wires in the fragment specific case, that was it. The error on my part was that when I did the AG reduction maneuver immediately after I put the fixation in place, it shifted a little bit and it was kind of like, this will do okay. Well, it obviously didn't. So.
All right. That is fantastic, Dr. Hanel. Thank you again.
I can make a point, Chai. Abhi, one of the problems you have to watch out for is that there's maybe a rotation of this volar lunate facet, and there may be widening of the sigmoid notch.
Yep.
So just keep your eye on that and maybe get a post-op CT scan.
For sure. This is actually a few weeks old. I made this talk before, but his like post-reduction x-rays, his 2-week follow-up x-rays look perfectly, like his rotation is back to normal and everything looks pretty nice. Point well.
You know, there used to be a book by duo called Seligson and Pope in which they emphasize that particular point about using external fixators or internal fixators as an augmentative tool. So anyway, there is, we do have time for some more questions, but we can always run into the break if we need to for more questions. But otherwise, in the interest of time, I'm going to ask Dr. Orbe to take on the next task of the volar lunate facet, please. Dr. Orbe, wonderful to see you, and thank you.
My pleasure, Dr. Mudgal. It's really an honor to be here. I want to also say hello to Dr. J.C. Jupiter. I'm honored to be in this program. So my task was to talk about the troublesome volar lunate facet fracture. This is my disclosure. Attention to this subject was brought up very early in the experience of volar fixed angle plating in 2004 in an article that was first author Harness, but the whole team was there. And this was the experience that we all collected because we started playing with volar fixed angle plates, and we all were facing this problem. The most common fracture line in a comminuted articular surface of the distal radius is the fracture line that connects the sigmoid notch with the interfossa sulcus, with the space between the short and the long radiolunate ligaments. And this is something that Gregory Bain taught us about. Not only is that the most frequent fragment, but the forces that the lunate applies to the radius are mostly concentrated in the volar aspect of the lunate fossa. And that creates a problem in fracture fixation because the lunate fossa is offset palmarly from the shaft of the radius. And unfortunately, that is where the force is being applied. And therefore, this is the explanation of the problem that we'll see. When we use a volar locking plate for a comminuted distal radius fracture, the volar lunate fragment acts like an inclined plane and generates a force that is directed in a palmar direction. But in most fractures, the buttressing ability of the plate is good enough to support that fragment and resist that force. The problem is that we cannot always buttress these smaller fragments because it's anatomically impossible. We all know that we cannot cross that rim on the volar radius called the watershed line and offend the Zoom's line, which basically tells us don't project anything above that level. So any well-fixed, well-applied volar plate has to be slightly proximal to the watershed line as they have thickness. No one is infinitely thin. So in average, I would say if you have a 5 millimeter fragment, it is impossible to support it at all. And many fragments that are much longer than 5 millimeters still don't have enough support. And we end up then seeing these disasters. The volar marginal fragment is problematic not only for mechanical reasons, but also for biological reasons. There is very little retrograde blood supply on the volar wrist capsule to feed these fragments. So I would assume the majority of them are avascular. And that's proven by the fact that many times it's not that they displace, it's that they simply reabsorb with time. And I think this process is identical to the reabsorption of the proximal pole of a scaphoid when we fail to provide stable fixation. We cannot get that creeping substitution of the dead bone by living bone. But if we are able to obtain solid fixation of your scaphoid fragment or your volar ring fragment, you will revascularize it. The volar marginal fragment can be either primary, you can identify it in your first attempt to treat this patient, or it can be failed. I think we've seen more failed than primary because we fail to recognize them, and we get away with it many times. So I think we should consider them that they're different animals, the primary and the failed one. Fixation options for these fragments include first, the first line of defense is a long buttress, but there are certain plates that have been designed, this one that Dr. Jupiter introduced me to, were designed particularly for volar rim fractures. And these are very effective, but they have to be removed because they cross the watershed line. In the past, we used K-wires, we used tension bands, we used wire forms, and now we have a hook plate extension to the volar fixed angle plate, which is a form of fragment-specific fixation. So this is one of these cases, and we fixed the fracture, and lo and behold, when we're satisfied with the reduction, but even though everything is in place, the fracture line is just at the distal edge of the plate. If we don't identify this fracture line, we're going to get into trouble. We must address it. This is the fluoroscopic lateral view showing you the fracture line is just distal to the plate. And the solution is fix it, and fix it right and then. My group, a few years ago, wrote an article on the use of the hook plate extension for these volar marginal fragments. And we found that whenever we could identify them primarily and treat them primarily, we got away with it. But whenever we tried to use a hook plate as a secondary forms of fixation, we really did not succeed very well. Only 50% of the cases got away with it. I had the blessing of being able to publish an article with my daughter, Carolina, who's my partner, on the on understanding the failed volar marginal fragment. And this is the natural history of these failed volar marginal fragments. In this case, we fixed what seemed to be a trivial fracture, but intraoperatively realized that volar rim, the lunate side, is very comminuted. So we use tension band technique. These are monofilament wires, and we thought that that would be enough, but that was not rigid stability. The fragment was avascular, and at 4 weeks, you could see the beginning of collapse, and at 4 months, you can see reabsorption, and now a defect on the lunate as the sharp edge of the plate is damaging the lunate. We think that we should consider the failed volar marginal fragment in 3 types. The acute, which is the one that occurs in less than 4 weeks, then you can perhaps get away with it, just fixing it. The subacute, which is the one that occurs between 4 weeks and 16 weeks. And these are the ones that have failed. They have bone loss, but they don't have permanent damage to the articular surface yet, so they can be theoretically salvaged. And then you have the delayed ones, the ones that are long enough that the articular surface is destroyed, and then the only thing you can do is some sort of arthrodesis, partial or complete. For the acute fractures, we propose that if the bone quality is good, you can try to fix it. For the subacute, you can try to fix it, but you must unload the lunate. So these numbers are very fluid. If you find a fracture that is 3 weeks old, 2 weeks old, and you're not very comfortable with it, fix it, but unload it, neutralize the forces. And a very good way of neutralizing them is with a spanning plate. Simply unload the fragment. And last, the delayed form, the one that has permanent injury, might need some sort of salvage procedure. If the rest of the fracture in the subacute phase, failed volar marginal fragment, no arthritis. If the rest of the fracture has not healed yet, then it's worth doing a redo and then neutralizing the forces. And that works pretty well. Another way of treating these fractures, if you have a failed volar marginal fragment and the distal radius has already healed, the rest of the articular fragments have healed in a deformed position, usually with excessive volar tilt. Another way of treating them would be to fix the volar marginal fragment and then do an opening wedge osteotomy to correct that excessive volar deformity and reduce the loads on the volar aspect of the lunate fossa. And that's what we did in this case. This patient underwent an osteotomy and a fixation and bone grafting of the distal radius. So this is done in 2 steps. Step number 1, you bone graft underneath the subchondral bone of the remaining volar marginal fragment. Step number 2, you do an opening wedge osteotomy of the radius slightly more proximally. So you end up having a basically neutral tilt, or if anything, slight dorsal tilt. If there's no hope for that wrist, you can do a complete arthrodesis, but I am partial to try to maintain some motion, so I'll try to do partial arthrodesis. A sample case is this lady that had all the telltale signs that you're going to be in trouble. It's a volar fracture. These tend to be the ones that get us into this problem. There's obviously a small volar marginal fragment. He was treated by a well-meaning surgeon, and no, this one did well. This one, we got away by fixing it. This is the one that failed. This one is 59, and it was treated by a well-meaning surgeon. Unfortunately, it fell apart. And this is the opening wedge osteotomy. First, you bone graft underneath the volar marginal fragment by utilizing autologous bone graft, but there's still a subchondral plate. So you can basically reconstruct that articular surface by putting a bone graft underneath it. But notice the excessive volar tilt. All the loads are going to be on your bone graft. That's probably going to not work. But if you do now a volar opening wedge osteotomy and jack up the distal radius to correct the excessive volar tilt, to regain the length lost in the collapse of the volar marginal fragment. And this time we're using croutons just to make sure that we get the slight dorsal tilt just right. And we confirm we did. We have redirected the forces in the articular surface. And unfortunately, now your radius is not anatomical. Your anatomical plate needs some modification. And this is what we obtained. Bone graft, autologous bone graft to the osteotomy to make sure it heals. The croutons are just temporary. And this is her follow-up. At about 2.5 years, she came back for a trigger finger. So not anatomically perfect, but functionally much better than an arthrodesis. So in conclusion, be vigilant for the volar marginal fragment. That's the first choice, is the only choice. That's the only time you can get a perfect wrist. And if you have a failed volar marginal fragment, you will require most often to unload it or to perform a salvage operation. Thank you.
Thanks very much, Dr. Orbe. That was spectacular. I'm just reminded, when I look at the technique of the osteotomy, it just seems to me so similar to what Frommersberger described for the malunited die punch, where he made that slot proximal to it and jacked it open and put a graft in there. So I would never have thought of it doing it this way volarly. So thank you. That's superb. Abhiram, you had a question?
No, I have fat fingers. I was trying to answer a chat. But no.
Okay. Here's a case for you. Let me pull up this case here. All right. So Dr. Orbe, this is a 62-year-old nurse here who works at our hospital, and she fell from a standing height. She was seen in the emergency room, and the x-rays on day 1 showed what she was told was a very trivial fracture, and she was sent on her way. And I think by the time she came to see me, it was probably a couple of weeks down the line. When you see someone like this, what are your elevator thoughts, and what are your treatment methodologies in assessment?
Yeah, thank you. I think this is a very serious fracture because that shortening that we can see is maybe 3-4 millimeters. For some reason, it's extremely poorly tolerated when you have a volarly directed fracture. These patients will present with loss of supination from the start. They will be very painful. So even though the first impression to some people that are not orthopedic surgeons might be, oh, this is not a bad fracture.
Right.
I think this is a very, very difficult injury to treat.
Do you, I mean, we got an x-ray of the other side because her radius scaphoid joint looked kind of strange to me, but she had bilateral radius scaphoid arthrosis with the scapholunate appearance looking just like this on the other side. So I'm not to steal Dr. Rush's thunder, but is this something that would concern you in your planning?
The scapholunate dissociation, it will. I would be certainly aware of it, but my experience is that at age 62, like my age, many patients have scapholunate widening, which is totally asymptomatic.
Right.
It might be just coincidental. I would probably take an X-ray of the other wrist because many times it's bilateral.
Yeah.
But this patient certainly needs to have that volar lunate facet brought up to the right level.
Yeah. So we got an X-ray of the other side. It looked identical, and she had developed radius scaphoid arthrosis on that side as well. So we went ahead. I usually get a CT because I find myself understanding the three-dimensionality much better with the CT. Would this add or take away anything from your decision making, or do you not bother with the CT?
I'll be honest, I probably will not bother with the CT because I think this is like a fracture of necessity.
Yes.
Even though it's not very displaced now, it will become more displaced as time goes by and we keep her in a cast. It will not heal in that position.
True.
I don't have access to a CT. I have to send my patients from my clinic. I'm in a private practice to get a CT scan done somewhere and then come back for surgery. So I just go ahead and operate it. But would I work in a big institution that had ready access to CT? By all means, I would CT them all.
Yeah. I think that's probably part of the problem because we have easy access to CT and we get it within a half hour. So, so that's what we did. And your approach to these is usually an extensile carpal tunnel, or do you go with the standard FCR?
This in order to get to the ulnar side, to the volar marginal fragment, I need to do the extended FCR approach. That means I have to release the FCR sheath as distal as I can. I have to take the FCR out of the trapezial tunnel. And there are these fibers that attach the FCR to the trapezium that I must release so I can then open up my whole volar radius and I can retract the tendons and the median nerve with no tension whatsoever.
Right.
And then I'm right over that volar lunate facet. If I don't do that, if I just do a Henry approach, I can't get there.
Right, exactly. So the way I was trained was we use an extended CTR approach, and the thing that what you say to avoid traction on the median nerve, I just put a bump behind the hand as you flex the wrist, so it stops you from cranking on the median nerve. And it also allows you to decompress the carpal tunnel. So we did that. And how do you identify the fragment? If you have everything covered by the pronator quadratus, I sometimes find in the older fractures, I don't know where the fragment ends proximally. So is there any trick you use to find the fragment proximally?
Yes. So I identify the watershed line. The volar rim of the lunate fossa is very prominent. It's also a rug of soft tissue, and you don't see. But if you run your finger, you can identify that prominent bump, which is the volar rim of the lunate fossa. And the watershed line goes right over. The watershed line is like a ridge in a mountain range. It ties all the peaks together. So I run my finger from ulnar to radial, and I with a marking pen, I can just mark on that periosteum where the watershed line is. And I will lift all the soft tissues, including the pronator quadratus with an L-shaped incision. I will lift everything up. And I don't go distal to the watershed line because then I will be releasing the volar ligaments, but everything proximal is elevated, and then I will see these fractures all the time.
And then if the fracture is slightly older, like by the time we got her into the OR, it was about 2.5 to 3 weeks, you routinely need to bone graft these with croutons?
I don't think so. If I can get a good reduction, the healing potential of the radius is so high. If I get rigid fixation, stable rigid fixation, it will heal.
So at this stage, what we did was, this is the technique that I use, is a cannulated headed screw with a washer. like a one-hole plate. And then I augmented that with a buttress plate to support it. And there she's at 9 years. So it withstood the test of time and the fragment didn't become dysvascular. I'm just looking at our time and we probably have 1 minute more. So the next case is probably going to, again, it's more of the same. He's a 61-year-old male who has undergone multiple debridements of his wrist for PVNS, done by the oncology service. And this was his initial appearance. And by the time he came to see me at 3.5 weeks, this was his appearance. Now, he's had multiple scars on the volar side, including an extensile carpal tunnel release approach to debride his PVNS. Would that influence anything for you?
Yes. This patient has an acute over chronic problem.
Yeah.
If he was unhappy with his wrist before because of the osteoarthritis, I might consider trying to do an operation now that would at least, minimize the possibilities of having to go back in again in the future. Which might include, I'm sorry, go ahead.
No, sorry, go ahead.
My first go around, I would try to do a proximal row to radius fusion.
Yeah.
And excision of the distal pole of the scaphoid, which converts the wrist into a ball and socket configuration.
Sure.
And has worked very well in many occasions.
So he was surprisingly reasonably happy with his wrist prior to his injury. So I took it upon myself to, again, here we go with the CT. And I felt that the fragment was sizable. You can see the cysts in his scaphoid from his PVNS. And we did the same thing. And the yellow arrow points to a bunch of PVNS poking through the capsule. So in this case, I used a T-plate and put a 3mm screw with the head through the plate, like shown here. And I think that phenomenon you described about dysvascularity of this fragment was emphasized on this one, because this looks pretty darn good here. But look at this now. Even though his motion is good, he's settled a little bit. And the multiple operations that he had, along with my taking on a 3.5-week-old, I think that point about losing circulation to this fragment is very real. So thank you, Dr. Orbe. Do you think, he stayed here. He didn't settle anymore. But do you think that's what happened, probably, that he lost some blood supply to that fragment?
Probably,
Yeah.
yes. The bone quality was poor,
yeah,
and there was some micromotion there.
He is still surprisingly happy, so I'm not getting any more x-rays. So the time's 10:30, and it is almost time for us to break for a mid-session break. So for those of you who need to get a cup of coffee, we will be back in about 10 minutes and resume with Dr. Roosh, who's going to talk to us about distal radius fractures with the scapholonate widening. Is it of any significance? So see you guys in a few minutes. Okay, Christopher, are we back?
Yep, all set.
Excellent, thank you. So before we start the next talk, I have a question for Dr. Hanel. Dr. Hanel, you here? We'll wait for him. Okay, Dr.
Hi,
Hanel.
I am here.
Hey, so there's, about 25 years ago, there was some papers on external fixation and the bad effects of over distraction of the corpus. And
Yes.
with that in mind, Mitch Harris has asked a very nice question. He said, how do you decide that you're not over distracting? And what are your tricks of the trade to know when too much is done?
I think that's a great question. And this question gets asked a lot.
Yeah.
And what I would do is I would ask you to read those articles again. Because as Jesse Jupiter pointed out in his historic book, that when those over distraction articles were written, they were written about placing the wrist in flexion and ulnar deviation, the so-called cotton loader position.
Right.
So I actually like them. I have never had a patient with reflex sympathetic dystrophy with bridge plate.
Mm-hmm.
I have patients who gets regional pain syndromes, but I've never had one with that. And so I limit my traction to 10 pounds.
Mm-hmm.
And the reason I do that is that one of my anesthesiologists pointed out that if you've got a guy who's got a perfect block, brachial plexus block, or is anesthetized,
right,
10 pounds is all you really need.
Right.
And so I limit it to 10 pounds. I do not take off my traction until my plates are in place. And so that's a great question, something that I'll add to this lecture.
Right, great. Thank you. We are going to carry on with Dr. Roosh, who's going to talk to us about distal radius fractures with a wide scaphoid interval. What does this mean? Dr. Roosh, you're going to tell us.
Thank you. I'll do my best. Jesse, I hope your golf game is improving since your retirement, and congratulations on a great course.
Yeah, I am improving.
So I've been asked to discuss the issue of the scapholunate interosseous ligament injuries in the face of a distal radius fracture. These are my disclosures. The origin of the concern over a scapholunate ligament injury seems to stem back from the work of Kirk Watson back in the early 80s. And this is sort of an interesting paper. It describes actually a round number of 4,000 wrist x-rays in which they then eliminated all other causes of arthritis and looked at 210 cases of degenerative arthritis and found that they had done 20 operations on 19 patients for this scapholunate ligament injury. 18 of 19 patients had, quote, less pain postoperatively. And they pointed out the concerns over this inexorable progression of arthritis. So it's a rather difficult article to follow, but certainly it alerted us to the dangers of scapholunate advanced collapse. And it really wasn't until we started doing a lot of arthroscopy for these distal radius fractures in conjunction with their treatment that Will Geisler published his classic article in the JBJS looking at 60 patients prospectively who had displaced intra-articular fractures and were treated with fluoroscopic and arthroscopically assisted treatment of these fractures. And what he found was that a significant number of them had interosseous ligament injuries, and he looked and found that 19 of 41 had scapholunate ligament tears. And he classified these injuries into his classic grade 1 attenuation to grade 4 drive-through. And so that's what we really were working with. This is a similar series from our group. And we compared arthroscopically assisted to fluoroscopically assisted reduction. And we found no substantive differences in our outcome scores. Primarily, we felt like because the technique of external fixation, despite augmenting it with some Kirschner wires, was probably not sufficient to prevent any collapse of these intra-articular fractures. And we found that 3 of 5 SL tears had at least a 10-degree increase in their angle. And we were pinning these with percutaneous pinning using our arthroscopic reduction. And this is a case of sort of what we were working with. This is a lunate impaction fracture that you can see here with a radial column fragment as well. And you can see that this would be one that would be very amenable actually to an arthroscopic approach that Michael Hasman is going to discuss with us moving forward. You can see the die punch fragment there with no really great way to get to it. But really what we found when we were scoping these was that there was tremendous chondral lesions associated with them. There you can see an avulsion of the ligament, and then we could debride these and reduce them and pin them, which was what we were doing at the time. Unfortunately, we were not. This was prior to rigid internal fixation with volar lock plating, and so these were not treated as you might now. But it led us really to kind of be interested in this concept of how SL tears will affect the outcome with an intra-articular distal radius fracture. And this is a database search of our patients, and we looked at displaced intra-articular distal radius fractures treated with a variety of techniques. And we were comparing the outcomes in patients who had radiographic evidence of an SL tear to those that did not have radiographic evidence of an SL tear. And the hypothesis was that there was no significant difference in the outcomes. And it was primarily my patients treated from 2006 to 2019 with a minimum of a 12-month follow-up. And we divided them into 2 cohorts. And one were those patients with SL angles less than 70, and cohort 2 were those patients who had SL angles greater than 70. And the parameters were examined both at baseline and the contralateral wrist, following closed reduction prior to surgical intervention, and then at final follow-up. And we used a variety of outcome scores that you're familiar with, including the Quick Dash, BAS, and Global Assessment of Function. And when we looked at the patients who we felt did not have an SL tear by radiograph, the mean angle was 58 degrees. And when we looked at those that had a SL tear, we felt by radiographic the mean angle was 74 degrees. So obviously not perfect, and MRIs were not obtained, but it kind of gives you a sense that there's at least a distinct separation between the two. The cohort 2 had obviously a significant increase in the SL angle all the way through their treatment. And when we looked at their outcomes, There was no statistically significant difference in their quick dash or their VAS or MGAF scores. So does not appear to be a significant difference at 1 or 2 years between patients who had radiographically apparent SL tears to those patients who did not have evidence of it. Who did have evidence of it radiographically, despite the fact that we were not doing anything to treat these ligament injuries at the time other than to reduce and stably fix the intra-articular fracture. And this experience probably ties in, I think Dr. Jupiter mentioned Tommy Lindau's ongoing analysis of his PhD thesis in which he looked at 50 consecutive patients who had displaced distal radius fractures. And he scoped those patients and assessed the concomitant soft tissue injuries and found that 32 of 51 had an SL tear. They were not all complete. They were untreated, however, just like in our group. They were evaluated, the tears were assessed, and they were not treated in any other way other than to identify that they were present. And then he looked back at those individuals again, and not getting it to advance. Okay, and he looked back at those patients at 13 to 15-year follow-up and really found that there were no significant difference in the subjective, objective, or radiographic outcomes, even long-term with the grade 1, 2, and 3. It should be noted, I think, that none of the patients, as Jesse pointed out, these patients did not have grade 4 SL tears, which may have a different outcome. So if that's the case, are there any scenarios where you feel that you want to intervene? And I think this was pointed out. I think if you have a young adult patient with a radial column injury like you see here in the x-ray on the left, that patient has an obvious SL injury. In this case, the scaphoid saw the brunt of the axial load and impacted the radial column. The lunate is effectively still on the lunate facet. And if you look at this patient long term, despite radial column plating with the adjunctive graft, you can see that the SL stays gapped, and the patient had a reasonably poor outcome from this injury. And probably in the future, these would be ones that I now pin temporarily for 8 weeks. And the other are, again, a very similar type of injury. Here you can see this is a B-type fracture with a lot of radial column injury. And in this case, you can see an avulsion fracture of the scapholunate ligament radiographically and fluoroscopically. You can see the fragment. And again, this is one that I would pin the interval in combination with stable volar plate fixation. So in those two scenarios, I still will temporarily pin them, but I do not go to the back and open these patients and do a formal repair. Why? Well, I think there's no single method of fixation of a scapholunate interosseous ligament that is so reliable that it is justified to make a second arthrotomy on the back and put in your anchors, etc., in order to potentially treat an injury that is not necessary to fix. I think that the natural history of a scapholunate interosseous ligament injury in the face of a distal radius fracture seems to be different than the isolated ligamentous injury that we see with our young adults that led us to coin the term a slack wrist. And I think that repair of the SLIO in the setting of a distal radius fracture does not really appear, at least in our study, to affect the short term, and in Tommy Lindau's paper, to affect the long-term outcomes either. But having said that, the caveat is that there are those scenarios with a significant collapse on the radial column that I will temporarily pin the interval. I think it helps to unload the radial column, and it certainly, at least in our arthroscopic versus fluoroscopic series, seem to provide adequate treatment. So I hope I haven't muddied the water too much, Jai, and please accept my gratitude for being invited to speak today. I think we all learn from each other. This is a group from a photograph from Beaver Creek when we were all a little bit younger, and these guys all taught me a tremendous amount, and I owe them a huge debt of gratitude. So we all learn from each other. Thank you.
Thanks so much, Dr. Rush. That was spectacular. I have to take some ownership for probably presenting one of the first series of this concurrence 30 odd years ago and promoting an active repair of the scapholunate dissociation. Of course, now with all the gray hair and 30 years later, that's a paper I would retract very gladly. So, because I agree with you. I'm not convinced it makes a difference. There is a question here from the audience, and they want to know, how long will you place the pin in the wrist? If you do actually pin the scapholunate, how long do you leave the pins in?
I have to say that, I think Jesse showed this about 12 years ago, the use of a cannulated screw instead of pins. And if I use a cannulated screw, I'll have a tendency to leave that in for a little bit longer because I don't worry about a pin tract infection. So a cannulated screw I leave in about 3 months. A scapholunate, scapocapitate pin I'll leave in about 8 weeks.
Right. Great. Thank you. Neal, you had something to share?
Yes, I have a quick adjunct to add in. So thank you, Dr. Rush. That was great. We wanted to go over quickly some thoughts that have been developing here, and it really kind of takes basis in what you've published and Chai's work, as well as many others. Again, as you noted, at time of arthroscopy, scapholunate ligament injuries and other ligament injuries are very common. But we started looking at these large diastases and in the setting of distal radius fractures. And when we have CT scans of these cases where there's large diastasis, we notice that in these cases, many of them either had this large malreduction or injury to the scaphoid facet, and some other injury to the lunate facet, where those two fragments are moving very separately. And so we began asking the question, what does this mean in the setting of distal radius fracture? And this is a different case where you can see the scaphoid is riding out of the fossa, and the lunate is sitting where the scaphoid is sitting dorsally and the lunate is sitting volarly. And so we found these cases to be very interesting and started looking at them more carefully. And the question becomes, what is normal? There's a situation where you have a distal radius fracture, and maybe the patient has normal diastasis, and that's similar on the contralateral side, as Dr. Orbe had mentioned earlier on. Or, as Dr. Rush was saying, maybe some of these are akin to a scapholunate ligament injury in some cases, but you don't have to treat them. Maybe because there's so much blood in the joint and it's, you have more potential for healing, or maybe there's another reason where it's related to these secondary restraints of the carpus. So Steve Lee, with these arthroscopic sectioning of cadaveric specimens, has shown that in order to get static dissociation of this scaphoid and lunate, you need to lose some of your secondary stabilizers, like the dorsal intercarpal ligament, your volar extrinsic, your STT ligaments. And you only get this large Geisler 4 dissociation when you have this SL disruption, or or your dorsal extrinsics are sectioned. And Greg Bain has done a lot of work on this, showing that, you fracture between your ligament insertions. So, you fracture between your short radial lunate and long radial lunate. The fracture lines tend to occur relative to these ligament attachments because the ligament attachment sites are very strong. When we had we found 26 patients with these injuries, with these large static dissociations on CT scans. And the way we started thinking about this is, in these cases, the attachment sites of the secondary stabilizers are broken off. They're involved with the fracture. So theoretically, anatomic fragment repair will help address these disruptions and restore the kinematics, even if the SL is torn. So again, what we are starting to think about is maybe there's different types of SL, the different ways to think about SL dissociation every time we see these fractures. One is SL dissociation that you expect that's happening on the other side, that's natural variation. And that's probably a large component of what we see. Secondly is a SL dissociation in the setting of where you have some injury to the carpus and maybe you get a tear of the SL, and it may be more akin to like an isolated SL dissociation, but maybe those do okay because you get so much bleeding into the wrist. It's maybe akin to a greater arc perilunate, where you get so much bleeding into the wrist that those patients do substantially better than these isolated SL reconstructions. And then finally, there's these large disruptions where you have these malrotation of these fragments and wide displacement of these fragments. And when you restore those secondary stabilizers, then you are in turn helping reduce the impact of that SL diastasis, SL injury, allowing us for the intervals to heal. And so these approaches where you do limited pinning or no treatment, it may help explain why those are successful in these situations. This is a case of Dr. Jupiter's, and you can see some of these similar problems. And again, this is from a while ago, and he treated the distal radius and had quite a good outcome. So thanks. I'm going to pass it over to Chai.
We have
I want to make one
minutes
about what you were showing there, and that is, your way of thinking about it as being somewhat different array of injuries it reminds me of the dislocation of the wrist is just a very different entity than the other ones. And you guys published, Dave and Jesse published a long time ago, a series of fracture dislocations, and just commented on how significant the soft tissue injuries were with those fracture patterns. And it's funny because I think nowadays we're doing a lot of bridge plating of those fracture dislocations because the fragments are so tiny and they do require neutralization. And we're not seeing the same degree of problems, primarily, I think, because we are allowing those dorsal extrinsic ligaments to heal without subjecting them to the loads that they would otherwise be subjected to.
So let me share a case with you and pick your brain a little bit about. So this is a 58-year-old male. He works in a desk job capacity. He is rather large and weighs at least 250 pounds. I think probably closer to 300 when I saw him. And he came in. This was a ground level fall. It was not like a high energy. So when you see something like this, Dr. Roche, what is your, how does your brain think on these things? Can you walk us through that, please?
Well, yeah, I mean, I think you kind of, if you're like me, you look at that and you think, wow, that's a tremendous depression of the radial column. Yeah. And that probably is, I think George commented to me a long time ago. He said, the radial column is really hard to support from a volar fixed angle plate. And so, that's one where you might really consider a fragment specific type approach because that radial column is going to be really hard to keep elevated with an isolated volar plate. So again, one where you might consider adjunctive type fixation, either a spanning plate on the second metacarpal or a radial column plate, in addition to stabilizing your volar ulnar corner there. So definitely kind of fragment specific. And then you start saying, for a fact that the SL has to be diastase there. And I found it even with a radial column plate that they can oftentimes, particularly in a big guy like this, it might collapse. Right. So that might be one where I would probably stabilize and then neutralize in addition to it with a spanning plate in a bigger male.
And now, how critical is it, or do you even bother? Because this is a question I get asked. Do you think there's any role for adjuvant imaging in this? And do you get x-rays of the other side?
I don't think it's going to affect what I do primarily. I think the question that you get into with these is, are you really confident that you don't have that depressed cartilaginous piece that's right in that apex where you drew your arrow? Sometimes you get a dye punch piece it's hard to visualize. So if you can kind of confirm to yourself on your plain films that you don't have to worry about that, then I probably wouldn't get a CT. But if I was worried about that, then I think a CT is nice because it's so frequent when you get into the operating room that it doesn't reduce, and you kind of are sitting there thinking, why isn't it reducing? And then you look at it and you go, oh, wow, there's a piece in between the two. So that's when I would get a CT.
Okay. So here we are. We got x-rays of the other side just to compare. And clearly there was a difference. Now, when you're counseling these patients preoperatively, if it's a distal radius, you give them one set of advice. But when you have this concurrent injury, how do you modify your counseling of the patient so they understand the gravity of the situation?
Well, I mean, I'm not as worried in a 58-year-old. I'm not as worried about his SL as I am that his radial column heals out to length so that you don't have any residual depression of the radial column. In that case that I showed you where despite a radial column plate, the scaphoid pushed it back down and remained depressed. That's what I want to avoid. So I'm not too worried about his SL tear, but it may help to mention that it's a difficult injury because of this associated soft tissues, but I don't think most patients understand it.
That is true. Your point about the age is well taken. If he was 25, and let's say he was an aspiring athlete, as everyone is, would you caution him about the future and range of motion or anything like that? Because there's mom and dad hovering in the background, wringing their hands.
Yeah, I mean, that'd be one where, I think a younger adult, it may be indicated to treat them. You don't see that pattern quite as much in a younger adult, but in a young adult, that may be something where you treat the X-ray just to treat the X-ray, and in a 25-year-old with anxious parents, that might be one where I would say I would pin it, and the patient would recognize that he had that treated.
Okay, so I was young and aggressive at the time, so I did exactly what you suggested in terms of columnar fixation. But there are two things that I see here is I use the Razzle technique, and I noticed that there's a little gap in the distal radial ulnar joint.
Yeah.
What do you think about that? And does that worry you? Because over the years, I've learned it doesn't worry me as much. But is that a cause for concern?
Isolated diastasis doesn't concern me as long as the radius is out to length. If I feel like I got my radius out to length, then I think that the DRUJ ligaments will heal appropriate. If your radius is not out to length, then that can be a problem.
Jesse Jupiter.
Yes, sir.
This somewhat resembles a Dumontier type 2 radiocarpal dislocation.
Yes.
And I bring that up because not only do you need to bring back the radial column, but in some of these, that ulnar styloid has the ulnar carpal, some of the capsule and ligaments. It may need to be brought back and repaired. And that may be influencing why you have a diastasis.
So, agreed. Exactly the things that I thought about at the time. Luckily for me, or I don't know, after the 6-week episode when I saw him when he was doing reasonably well, he never came back. So I have no idea what's happened to him. Sorry, but that's my case. And I think at this point I will stop sharing and invite Dr. Hausman, who is going to talk to us about the role of arthroscopy in the management of fractures of the distal radius. All yours, Dr. Hausman.
Thank you very much. Let me share my screen. Can everyone see that now?
Yeah, it looks good. If you could start the presentation mode. There we go. Perfect. Thank you.
Disclosures. Thank you for the great honor to be part of this today, and congratulations to Jesse and his enduring legacy. My topic was applications of arthroscopy to wrist fracture, and I think it's mostly, a lot of this is like advertising. The first two questions a patient asks, at least in New York, is it laser? And I think we have to say no. And then they ask, well, is it arthroscopic? And that's really all they care about. And it's definitely great advertising, a great catchphrase. Yesterday, I got an email, Jesse, from Mass General offering me a fantastic new arthroscopic treatment for my subscapular pain. So that's totally appealing. The question is, how useful and beyond the hype, are there actually useful applications for this? So let's go through some of these potential applications of arthroscopy that I've listed here in 6 categories. First is, of course, reduction confirmation. So here's an intra-articular distal radius fracture. I'm concerned about this volar fragment and possible loss of reduction. And using dry arthroscopy, I can certainly confirm that that is anatomically reduced. Is that useful? Well, I don't think we know. but it is certainly feasible. And the point I'd like to make here is that I think all of these procedures are done much more easily using dry arthroscopic technique. And so I virtually never use fluid for my wrist arthroscopy. Does this actually make a difference? Well, I think we're all familiar with a series of papers from Paco Pinal showing modest improvements with arthroscopically assisted reduction, but really no clear evidence that makes a major difference in outcome. And of course, we have to think back to the paper that Jesse would probably most like to retract, if possible, which is the importance of a 2 millimeter step off. And then there are reports of arthroscopically assisted osteotomies for malunions. And again, you can improve the radiographic parameters, but this doesn't really seem to reflect itself in the outcomes. So, I think the utility of arthroscopy for fracture reduction is still questionable in terms of whether or not it actually affects clinical outcome. I think it's a different story with treatment of associated injuries. It is very helpful in identifying intercarpal ligament injuries and TFCC injuries. And there's good evidence that you can pick up injuries that are not apparent from the X-ray. And frankly, we're not going to order MRI scans on all or even a small majority of our distal radius fractures. And so it's good to have a way to diagnose these because the incidence of intra-articular additional pathology is substantial, and it's somewhere between mid-30s for TFCC injuries, much higher with extra-articular injuries, and maybe 20-30% of unsuspected SL injuries. And I think that's important because the best results from treating these injuries come from early treatment, and it's technically easier to get a good repair. So here's data from France showing that arthroscopically SL laxity could be appreciated in 70% of the cases with a radial styloid fracture. Chai's case that he just showed is a good example of that, and he did a wrestle. And the same thing with TFCC tears. So I agree with Jesse that basal ulnar styloid fragment is probably significant and probably associated with the DRUJ diastasis. And that TFC could be easily repaired, again, using a dry arthroscopic technique. The results, I think, of the Rassel procedure are best in fresh cases where there isn't a fixed deformity. And this is such a case associated with a distal radius fracture. And we get a great view using the arthroscope of preparing the surfaces and then confirming the position of the guide wire right in that subchondral bone, and then the reduction and placement. And we can make sure that that is perfectly reduced and then place our screw. So I think arthroscopy, and there's a nice anatomic reconstruction of an acute SL injury. So I think there is some utility there. Another area is when you have a slightly ulnar positive situation, you can certainly inspect the TFC while you're fixing the distal radius fracture. And if there is evidence, particularly of previous ulnocarpal impingement, it's not difficult to do a wafer procedure, as you see here. So this was a distal radius fracture. There was a tear. There is chondromalacia, reciprocal chondromalacia. And while I'm there fixing the distal radius, I can do a bit of a wafer procedure here. And there's pretty good evidence that is helpful, and several reports that the complication rates are much higher for ulnar shortening osteotomy if you have to do that. So treating the ulnocarpal abutment and the chondromalacia at the time of the distal radius fracture may be compelling. Finally, one of the more interesting areas is Greg Bain's work on contracture treatment. We all have difficult patients who are very stiff after distal radius fracture. Pignal has reported intra-articular fibrosis, these dense fibrous bands. And Greg Bain has done anatomical studies for a radical resection of the capsule, leaving only the ulnocarpal ligaments and demonstrating that this is pretty safe. Certainly, we do this all the time arthroscopically in the elbow with excellent outcomes, and this may be applicable to the wrist. So this is one of Greg's cases using this duckbill forceps, and you see the tendons there, and he's simply removing all of that capsule. This is a case of mine, very stiff after a four-corner arthrodesis, which I think is common. And there are the extensor tendons, ECRL, ECRB, and you can use a shaver. This is a little Littler scissors that I'm using, and you just want to cut and remove, do as thorough a capsulectomy as possible. So I think this is preliminary work, but it may hold promise for treating stiff wrists, much the way that we treat stiff elbows. And there are some early reports of really substantial improvement in range of motion and grip strength. So work in progress. And one other report from Italy, Riccardo Lucchetti, showing some more modest gains in range of motion. And finally, another paper from Dr. Pignal about release of the distal radial ulnar joint to regain supination. So beyond the hype, I think there are useful but limited applications, and I hope I've shared some of these possibilities with you and stimulated some thought, and that our attendees will take this to the next level. And thank you again to Chai, the organizers, to Jesse, who is just a beacon of not only innovation, but sanity in these treatment of wrist fractures. Thank you very much.
That was wonderful, Dr. Hausman. Thank you. That picture of Dr. Jupiter's is so Jesse, if I may say that. It epitomizes everything I know about him.
But look how far ahead he was. He had my whole lecture years ago.
Yeah, I always like to joke with him and say there's a fine line separating brilliance from insanity, and he habitually keeps crossing from one side to the other.
Right.
All right. So I think, Abhiram, you had some cases to discuss with Dr. Hausman?
Uh-oh.
I have one.
Okay, go for it. And while you're loading that up, there's a question from the audience for Dr. Hausman. Do you remove the SL screw later? And if so, when do you remove it?
So that's a great question. The answer is in an acute case, unless there is windshield wipering or signs of failure, I do not remove the screw. For chronic cases, what we've started to do is add a second screw, a scaphocapitate screw, to really lock up the scapholunate joint, and that does have to be removed. I wait at least 6 months, sometimes a year, but the scapholunate screw I don't habitually remove.
Great, yeah. I think along the same lines. Abhiram, all yours.
All right. So this is a 26-year-old young, healthy female PhD student. She's right-hand dominant. She fell while going over her handlebars on the bike path near MGH. She sustained this intra-articular distal radius fracture. She came to the ED, was close reduced. And then by her 1 week follow-up had lost her reduction. And so I guess we can pause here and say, so you're seeing this patient in clinic, young patient, dominant side, loss of reduction, planning to treat surgically. How do you make the decision for whether you add arthroscopy to the consent or not?
I think it's sort of player's choice. I mean, this is intra-articular, it's displaced. I would be concerned about the SL ligament. So something like this, I would probably add arthroscopy. If I were getting a pre-op CT scan, that might change my thinking on that. But if I was not going to scan this, then I would want the option on the consent of doing an arthroscopy.
Do you do a dry arthroscopy, wet arthroscopy, or how do you make the decision one versus the other?
Always dry. That way it doesn't interfere with your fixation. You can see better. I mean, it takes a few extra minutes because you have to establish an air inflow portal and suck out and clean out all of the hematoma. So when you first start, you can't see a thing. And it's 5 minutes of sort of vacuuming and tidying up, but then you get a good view, and things don't get swollen if it's dry. If you're in a training program, the residents and fellows can do some of the arthroscopy because you can be confident that it won't swell and you won't lose your view.
Do you ever add a carpal tunnel release for worries about swelling? Although you just said that it doesn't, but is that ever a concern?
No, unless the patient has a history of carpal tunnel symptoms pre-injury. I think you should ask that routinely, but I rarely see that, and I don't decompress the carpal tunnel.
So these were my final fluoro films, but I did do arthroscopy. The SL was intact. I started out with this gap, and then with a series of joysticking and compression, managed to reduce this gap to what I thought was fairly anatomic. And then
awesome.
And then checked the SL, as you mentioned, it was intact. So she followed up. She's now actually 4 months post-op and has full range of motion, no pain, no restrictions, back to activities. Right.
So my only comment would be, it looks like you didn't fill the proximal row of pegs. And I'd be interested in others' thoughts. And she's a 20-year-old, so granted, her bone quality is probably good. But I'm always concerned about settling around the pegs, particularly in the geriatric female population. And so I think you want as many boards in that fence as you can get from the lumberyard. I don't know what other people think.
We had actually looked at this. David Ring is here. I know David and I had compared our series because he was, if I remember correctly, 1-row guy and I'm the 2-row guy. So we decided to compare our outcomes. And what we found was 1 versus 2 rows did not make any difference to final outcomes. And the only thing, and this is, I love to make fun of David for this, was that I believe there's a slight superiority of radiographic outcome in my patients over his, and it was really, really slight. So that's one thing I got on David. David, if you're listening, yes to you, buddy.
What might be helpful for our panelists is to go through the some of the technical aspects of the surgery when you're doing this arthroscopic reduction. Abhi, let's talk about what you do with the plate, to get it started. Oh, I got the stuff. Okay, go ahead.
Oh, I actually just follow the Paco Piñal paper. There's like a nice technique. I'm getting the best. He has a very fun quote in it, which he said he once tried to reduce everything without putting the plate on arthroscopically, and it was impossible in his hands, and he welcomes another surgeon to try to do it. So I thought that quote was kind of nice. And so I try to get the best reduction I can, put the plate on, put some K-wires in, and then dry arthroscopy, and then use the arthroscopy to fine tune the reduction. And there's a nice series of papers for each of or nice series of pictures for each of the different techniques, but by no means am I an expert. So others should definitely chime in with their better techniques. But this is essentially what I did for that other patient.
So there are a couple nice adjuncts to trying to get your reduction. Dr. Jupiter has this clamp that he likes to use in the OR, and that can be quite helpful, when it's open and you're applying this pressure dorsally. The difficulty here is your scope's coming in the back dorsally to have everything in place, and having these small clamps to bring up the fragments, I think are necessary, important. So I think you have to have some of this additional equipment available. Other technical points that I think are useful to make note of is once you put a K-wire into a fragment, if you move that fragment slightly, the tendency is for the K-wire's already made that tract, and that fragment's going to fall back into that tract. So I think that some of the things to pay attention to are you have to move that fragment enough so that tract is in the same place, or don't burn all your distal pinholes. Dr. Hausman, what other technical pearls do you have for us?
Well, I think one thing that's really useful, you showed on the slide that you're performing this on a hand table with traction. So you definitely want finger traps and traction. If you can reset your brain to view from the palmar surface with the arthroscope, then you don't have to keep going back and forth. And, Dave Slutsky and others have been big advocates of a palmar trans FCR approach. So it's a different perspective. You have to get accustomed to it, but you're right there. And so to make a little capsulotomy and stick your scope in the volar side is quite easy and useful.
And the trick to getting that volar portal is to take your narrow probe and use that as a switching stick to drive it through the aperture between the radioscapal lunate and the long radial lunate. You push through that, and you see it on the other side, and you use that as your switching stick to bring volarly, and so you don't have to struggle with making that portal.
Yep.
So, is Dr. Orbe still here? Yeah, we may have lost him. Any tricks from you, Dr. Hanel? Any surgical pearls when it comes to arthroscopy? In the
so for me, as I have tried to use volar dry scope, and I don't do a lot of arthroscopy. I'll admit that. And so for me, it's not terribly disorienting. It's always disorienting. But I can tell the difference between a 1 millimeter step off and a 3 millimeter step off. And so that's sort of what I do with that. But I mean, some of these reductions that Delpinel and Brunier and in France that they do are just spectacular. And I certainly have to compliment them for that. But I think it's a great adjunct. It is. And I think that the slide that you showed with the reduction, the second slide on this series from this article, not the one where it shows that one right there. That's basically what we're doing with every one of these fractures, these really comminuted fractures. And I think it also tells you that one of the things you can do from a small dorsal incision is lifting those fracture fragments up and bone grafting them, and holding them up with bone graft. And we haven't mentioned that, but it's still an adjunct to it. I still take advantage of that.
Yeah. I mean, if I had to poll the audience, because this is a webinar that's going across the world, if you had to convey to other people across the world in resource-limited environments about how often you use this in your practice of fixation of distal radius fractures, would you use a number, Dr. Hausman? Less than 10%, more than 10%?
Maybe 10%.
10%. Yeah, so it's not a large number.
No.
Yeah.
Same for you, Dr. Hanel, I suppose.
Yeah, absolutely. I'd probably even be less than that. So
great. Any questions from the audience, Rohit or Abhiram? No. Good. Then we will go to our last talk of the session. It's going to be Dr. Jupiter talking to us about his approach to malunions of the distal radius.
Okay. Okay. I guess I'm all set. Thank you again for all the panelists and my colleagues putting this together and participating. It's really quite a fascinating and educational experience. And I hope we can continue to do this every year, perhaps in person. These are my disclosures. What are the issues today? And let's go through these individually. First of all, the indications should be relatively clear, both clear in surgeon and in patient's perspective. What the gains are we looking for, and what would be the problems that we may be able to address? But in certain things may not be useful. And I just bring up one, is a fixed carpal instability. If a patient has had an intercarpal ligament problem that we've heard about and has a fixed intercarpal instability without realigning the ligament, the intercarpal alignment, and that patient's primary indication for having something done is to get more motion, that may not be effective with an osteotomy. And furthermore, as we learned from a lot of recent literature, X-ray deformity does not always correlate with a loss of function. And this has become a rather perplexing situation in large studies, for example, in UK and elsewhere, showing that perhaps there isn't a need for operative intervention for every very displaced fracture in the older age patient. The other important thing to realize is that when we're looking at X-rays, two-plane X-rays, we're not really understanding the vector of the deformity. And the problems that occur when we have an angular deformity, among other things, is it affects the loading of the cartilage. And some patients may have a pretty good motion, but have pain. And the pain is often due to overloading of the cartilage on the radiocarpal joint particularly. And we may see dorsal subluxation that can be correctable with the osteotomy. It's been shown from many biomechanical studies that increasing the angular position of the end of the radius increases the load onto the ulnar side of the wrist. I think the midcarpal joint is one that may show a problem that can be corrected with an osteotomy. And we call this a type 1 adaptive dizzy deformity. And these patients may be more loose jointed, and they have a compensatory midcarpal flexion and present with pain, and pain may be coming from a painful synovitis. And this is corrected with a osteotomy. Ulnar impaction as well is something that from loss of radial height and malrotation can present with symptoms on the ulnar side. So these are all reasons to consider intervening in the symptomatic patient with load transfer onto the ulnar side. We went through this throughout the whole symposium about articular realignment, and certainly that, and in association with soft tissue injury in the carpus, may be indications for intervening with corrective osteotomy. The same with strength. Strength with a dorsal malunion will affect the grip strength, and it changes the moment of flexor tendons and will be problematic. On the volar side, volar malunion will tend to affect forearm rotation for sure, and these patients lose supination and should be addressed more quickly. What about timing? Well, if you're faced with a young active patient, particularly with a clear deformity, and they have regained digital motion and adequate wrist function, I don't think there's a need to go through the sequence of therapy and rest and splintage and whatever. And it struck me years ago when I saw some patients with this that maybe I should go in earlier. And I looked at a group of 10 patients, I think, that were done within 5 to 8 weeks post-fracture, and compared them with those that were seen later with the remodeled callus. And it was clear that the advantages were substantial. There was less soft tissue contracture. There was no need, if you found the location of the fracture site, to consider a big bone graft. Obviously, decreased total disability and earlier return to work. Preoperative planning has gone through a number of evolutions and some very exciting approaches now. We used to base these on X-rays, and Diego Fernandez showed this very clearly by planning out on the normal and then abnormal superimposed radiograph tracings to define this, where you would do the osteotomy, how to do the osteotomy, and what requirements there might be for internal fixation. and is illustrated in one of his cases here, showing that. A second way would be to try to understand the deformity from the point of view of alignment in terms of this, what's called a finite center of rotation that was developed by Lottie Nodge in Switzerland. If you take the abnormal tracing of the X-ray and superimpose the normal, then take the points of the dorsal most normal and dorsal most aspect of the abnormal and do the same on the volar side, and then drop perpendiculars splitting those two lines. They will show you where they end up. And if they end up on the volar side in the volar cortex, then you likely would not need a lengthening and a bone graft. And you can do this and effectively give you some idea that if you look at the lower right side with those two perpendicular lines meeting way off the surface on the volar side, that this will require lengthening and then some type of interpositional support along with your plate. And Paco Pinel has expanded this to be able to get a better idea of the rotation. And that's the one thing of all these tracings that don't show effectively how to control the rotation. We looked at a series of using the materialized preoperative planning of corrective osteotomies, comparing the 3D planning versus standard planning, and found that there was a little bit of improvement, not substantially, but these were extra-articular malunions. I believe that the intra-articular malunions may be well served by a computerized planning. Here's a patient who had a malunion that was worked out with computerized planning, and it teaches you to understand the malunion a bit more clearly before you go in the OR. You'll create a jig of sorts to teach where to place the pins and then to do the osteotomy. And hopefully the computer has it correct, and then the result can be more predictable per se. Operative tactics, have they improved? We moved away from this first approach through a dorsal approach? Well, the goals remain the same. They're to reorient the articular surface in load transmission, to reestablish the normal corporal kinematics, and to reestablish the normal distal radioulnar joint. I think the advances that have occurred more recently have been greater acceptance of doing many of these through a Palmer approach, which is not new. Ulrich Lantz described this in the late 1970s, and Orbe as well has described this more clearly in the last 15 years. You can use the plate in the volar approach to help the correction in both the frontal and the sagittal plane. You can even define how much length you'll need by placing a screw in the third or fourth or fifth hole, and it might tell you how much length you can get with the length of the screw. This is worked out by fellows in Singapore. So if we wanted 10 millimeter length, 10 millimeter screw in the third hole, we would get an 18-degree correction. So here we are. This requires an adequate amount of structural bone in the metaphysis, because once you're putting the screws in the metaphysis, you're putting a lot of stress on this. But be able to do this and then do the osteotomy and then correct it by bringing the proximal limb to the more proximal radius and correcting the rotation by virtue of the fact that the anatomically shaped plate will provide the rotational correction as well, and the deviation as well, and lengthening can be done. So here's a case of Dr. Fernandez done through a volar approach, and you see the offset of the plate before the osteotomy. And one important point about these is if you're doing this, you have to release the dorsal side of the periosteum in order to be able to mobilize that distal fragment. And there's also an important part on the dorsal side to make sure there's not a spur that remains, because it can cause a problem with the extensor pollicis longus. So by getting a good release, and here releasing the dorsal capsule, a dorsal bone repair that was from the fracture. And then the other question is bringing back the shaft of the radius to the distal fragment. And sometimes a lamina spreader put between the radius and the ulna will be able to correct this deviation. And here's a plate being applied, and then a screw proximally to get a push-pull technique to get length and help in the overall correction as seen in this intra-op fluoro. And then these can just take cancellous bone graft. In some cases, people have done this without bone graft at all. So how to plan this from the dorsal side becomes a little more difficult with a rotational malunion, but it has been shown to be very effective with the lower profile implants. Intra-articular malunions became an area of interest of mine, because the question came up is, can you do this? It might depend on the fracture pattern. The chronology, is that important to do these as early as possible? And whether or not the soft tissue conditions would allow this. I think it's really important if you can get the original x-rays, the original fracture patterns, to get a better idea, because sometimes it's not always obvious. I think 3D CT scans, as well as 3D reconstructions, and we heard wrist arthroscopy, all may play a role in this approach. If you have obvious cartilage damage with degenerative changes, chronic synovitis, or a very complex intra-articular pattern, it may not be amenable to this approach. So I think starting out, if you do have, we saw about the volar ulnar corner problems, if it can be well identified, it may be a very good indication. And to do it as reasonably soon as possible, bearing in mind that at a 4 to 8 week time, that bone may be soft and not amenable to a lot of manipulation. And if there's arthrosis coming, then the radioscapholunate arthrodesis may be appropriate. We heard about arthroscopy as well. This is a case of Philip Stockman's using the 3D computerized generated evaluation. Here's the 3D CT scans. And then what the computer has done is identified the line of a deformity, and then gives you an idea of where to make the cut and where to elevate the fracture fragments. And this was done here, and at 4 weeks post-op and 8 weeks post-op. So that's Philip Stockman's case in Belgium. And we saw Paco Penal's work with the fractures, but he's also done some outstanding work using specialized elevators that he's made to be able to elevate intra-articular malunions. And this may be a very a useful technique, particularly as it doesn't require the need for a 3D reconstruction, but rather you're doing it under direct vision. And here's a case from his article of this. What about combined? This is a patient I saw in 1986 and had a very complex intra and extra articular malunion. And I was able to get bone models made off of CT scans. And the nice thing is you have really the whole fracture in your hands with the opposite normal side as well. And you can plan out your cuts very effectively. And we're looking at a coronal view. You can see the malrotation and the extension of the metaphyseal fracture. And by doing this and planning out, it seemed the logical thing would be to elevate up that lunate facet, then do the metaphyseal osteotomy and see what we could do. And we did that. We had to remove part of the ulnar head and then remove the plate afterwards. It was a dorsal approach, but it worked out very effectively for the patient. And more recently, we put together a series of 17 patients from these 4 clinics and looked at these patients, middle-aged for the most part, but the time from injury, interestingly enough, was 11 months. And the step off was visible, was 4 millimeters per se. And this is the type of patient that was when we could consider, where you see an intra-articular impaction of the lunate facet and a metaphyseal malunion. And this is a case of Juan del Pino in Madrid. And the other thing about this is that it sometimes more clearly identified than in a fracture. So we've got the major fragments. He approached the lunate facet fragments by osteotomy through them and realigning them to the radial column, and then did the metaphyseal osteotomy as seen here. So there's the lunate facet, and there's the metaphyseal osteotomy. Brought these two together and an intercalary bone graft, and then fixed these with small plates and had the plates removed. And this is an 11-year follow-up. So you see no degenerative changes over time. In our series, all the patients healed. There were a few soft tissue problems, and hardware removal, particularly in the European group, was prominent. But the range of motion and overall strength and patient satisfaction was very high. So that is a good indication. Bone graft we talked about a lot in the past when we were using less stable fixation. And once we had the locking plate, it struck me, did I need to put in this corticocancellous wedge? It would never fit in the three-dimensional deformity and defect that you have as well. It would either fit on the dorsal side, but not the volar side. So I looked at 10 patients doing that technique, and then 10 patients with the initial locking plate and using just cancellous bone, and found that the results were fine in terms of healing, but there was much easier to do. And I think the non-structural grafts were very effective if you had stable correction and holding it with a locking plate or external fixator. Otherwise, you would need the corticocancellous graft for the intrinsic stability. So here's a patient, a more recent patient I did, and I switched to not only using no bone graft, but using a type of bone cement that filled the defect very well. And we published this in the Journal of Hand Surgery. The distal radial ulnar joint has obviously an important role in getting overall function, and there are many situations where one may have to address these as well. And lastly, there's not always a perfect situation when you're doing these. And we looked at the planning cases versus the 2D versus 3D, but just give you some idea of the type of complications you may have. One non-union, some tendon problems, but overall, considering the complexity of these, it was very minimal. And the last thing I just wanted to mention, to repeat, that since we're doing these through a volar approach, be mindful of the dorsal side, because we saw some patients who sustained an EPL rupture, even though it was not a screw going through, it was not the saw, it was probably from a spur or the Lister's tubercle that had not been released. And so I think this is just a message to be mindful of this problem. And here you may see a spur like this, and look at that after the osteotomy. If that was not removed, that would be a real cause for concern. So in summary, malunions remains one of the more common complications of non-operative treatment. Intra-articular malunions we've seen from a variety of approaches and problems, and it remains still an issue. And if symptomatic, extra-articular malunions, I think with a radial osteotomy can improve function overall. But careful patient selection and the correct indication and good surgical technique should give you a good result for your patient. Thank you very much, and thank all for participating in this. It's quite an honor.
Dr. Jupiter, that was fantastic and so comprehensive. Yeah, I almost think we should keep this recording as essential watching for all the residents and fellows for the future. I mean, this entire conference should be essential watching for the breadth of topics it's covered. We have a few minutes so I think this is one of the things, one of the cases I wanted to share with you because of the important point you made for me. So here we go. So this is a 28-year-old female. She works in a desk job capacity, and she was treated non-operatively at another facility. And when she came to see me, her radiographs looked what I thought was pretty reasonable, not much in the way of pain. She had great flexion extension, but limitation of supination. So when faced with something like this, Dr. Jupiter, what is your thought process in analyzing this and counseling the patient?
I think if you look at the X-ray, you see that she's her distal metaphysis is volarly tipped. If you look at where the lunate is,
yes,
you draw a line down the capitate lunate axis.
Yes,
it falls below the radius.
Yes.
So there's one of two things that occurs. As I mentioned in the beginning, volar malunions, these patients often lack supination.
Right.
And so that may be a combination of the deformity with the altered sigmoid notch, as well as contracture of the volar radio-ulnar capsule.
Right.
So most of the time it can be corrected with the osteotomy. There are times that some patients will have a very stiff radio-ulnar capsule, then that's part of the loss of motion. But I think an osteotomy would bring her back, her supination.
Would you get further imaging for this? Or you're happy with the amount of info you have on the plain radiographs?
I think it's pretty clear.
Okay. Well, I got a CT anyway. So there we are, and exactly what you said. She's tilted quite a lot volarly. Now, for these, do you prefer to go the volar route, the dorsal route, and what sort of bone graft or bone substitute would you use?
No, I don't think you will need bone graft. Here the problem is volar. I would go for sure to a volar approach.
Okay.
And by an anatomically shaped plate, you will correct the rotation.
Yep.
And the realignment.
So that's pretty much what I ended up doing. Although I felt a little leery about leaving the gap the way it was, so I filled it with Norian because she had some reservations about harvesting bone. And exactly as you said, I could correct all the features through the volar approach. And there she is. She got back her rotation. So she was very pleased. I'm going to stop there, but I think, Neal, you have a case, do you?
Sure. I'll show a really quick case, and then maybe Dr. Jupiter, you can walk us through what you would do. All right, another dog.
We'll let the dogs out.
So this is the only picture that we're going to start with. But Dr. Jupiter, this is a patient that saw somebody had their distal radius pinned. There used to be a styloid pin, but the styloid pin was removed at 1 month, and then the fracture collapsed dorsally. Just starting here, what would you do with this patient? What's your decision making to treat this patient non-operatively versus do an operation at this point? What would you do here?
Obviously what we want to know is, why is the patient in my office? What's his problem? Is it the appearance? Is it function? Is it rotation or grip strength or pain or a lack of flexion?
So the patient, there's a mistype. I made a typo here. It's 8 weeks, but the patient basically is doubting the treatment, just seeing the X-rays, just noticing the wrist doesn't look the same as the other side, but hasn't really rehabbed this, hasn't done much to it.
The thing is, what's his future? Is he a young or old or what?
She's 60, she's a housewife. She's a homemaker.
Oh, well, at 8 weeks, I would talk to her about what the likelihood will be functionally with this. If she's in a non-dominant hand, a low demand situation, it's worth then letting her see how things go. If she's an active person with a forceful demands of work or sport or whatever, I would explain to him the potential problems and then explain what it would involve, realigning it. If it's somebody else's patient that comes to you, it's not so hard to do. If it's your patient that, your pins have slipped and all that, there's an inherent resistance to jumping ahead. But I think this is one that functionally could have some major problems. And at 8 weeks, I would consider an osteotomy.
So with this patient, my thought initially was similar to you, is maybe just take this pin out, rehab the patient, But then the patient started saying, I'm getting tingling and numbness of my fingers. I'm having this issue. And then we began having a discussion about what makes sense in this situation, because likely she was going to move towards at least something to address the nerve. So after discussion with her, we opted to go to surgery for an osteotomy. So similar to what you've described, and we used all the things that you taught us with the chips. But I think that this final kind of discussion is, the role of osteotomy, I think that it has to be selective in who you choose to do the osteotomy on. So
yeah. Well, just correcting the deformity will correct her carpal tunnel. People have looked at that with just taking the pressure off the nerve because it's angled will help that as well.
But looking at the bone quality, I suspect she's older, right, Neal?
She's older. Yeah, she's in her 60s.
Given that she's of that age, I would not use the word older with Dr. Jupiter. But given that she's that age, would you feel comfortable just letting it, leaving her without a carpal tunnel release formally, or would you?
No, I would do the carpal tunnel. I thought you were going to say, would I feel comfortable doing the carpal tunnel and letting it heal further and see how she does?
No.
And no, that just again depends on the patient.
True.
If she's there, I can't tell you how many patients would, when I talk to them in the initial fracture and it's very displaced, and I'd say, I think you'll heal. And is older patients, quite older, and but your wrist will be crooked, but your hand will work. And they'll say to me, "Doctor, look at me. Do you think at this stage in my life I care how my wrist looks?" Right. And that's the point. Yeah. I mean, if she has rotation, has adequate flexion extension, and doesn't care about how her wrist works. Right. Then her carpal tunnel is her major problem.
True. And all of us have seen enough patients who come with old malunited fractures of the distal radius whose only problem is carpal tunnel, and you release it with an extensile carpal tunnel and you do just fine.
Yeah, that's right.
We have one more question. Oh, go ahead.
Go ahead. Yeah, there's a question from the audience, I see.
Yeah, and I wanted to ask Dr. Jupiter a question. You mentioned the use of computer-aided planning for osteotomies and how you thought there was a role for intra-articular malunions. I wondered if you could comment about the role of experience as it relates to osteotomies, as well as looking into the future for younger surgeons coming through the pipeline. If you only get used to using the computer to do this for you, what the role is of experience. Because I can recall as a fellow seeing you do these, and it just seems so easy, but it's clearly not. And it's because you have lots of experience. So your thoughts on that?
Well, that's a good point. Once you do that computer, it's wonderful to have it help you identify the site and location of the malunion more clearly. But then it gives you this jig that tells you, here's where you make the cut. Well, that you are giving your faith into that computer. And I never liked that. Okay. Yeah. So I think the first part is great, the planning. The second part, I'm not sure. And if you become, as you point, so dependent on it and you're actually off, you're not going to get a good result. So the answer to your question is the case that Chai showed, a volar displacement or an isolated volar lunate facet or dorsal lunate facet is identifiable and maybe the way to start your career, so to speak. To do these complex intra and extra articular malunions, that takes a little bit more experience.
So that's phenomenal, Dr. J. There's one last question. And And I'm not sure this is addressed to you, Neal. Can you take a look at that?
Oh, yeah. So the question is, in patients, basically, what are the factors? How are patients affected by their psychology with distal radius fractures? And David Ring, who's joining us as a attendee, has done a lot of work around this, and I think that it's clear from his work when he was here in UT Austin, shows that psychosocial factors play a large role in outcomes, and oftentimes can overwhelm, even the physical pathophysiology at the wrist. So it's an important consideration to think about.
I think I echo your thoughts, and I also think it plays into patient selection even before you go down the road of surgery. Forget outcome, but you have to get a sense for how you can even select a patient, So I think, like all good things, we are at the tail end of our session. It's been a phenomenal 3.5 hours of Distal Radius Fest. It's been a lot of fun. I think we've learned a lot. And I can only thank Dr. Jupiter and Beryl for still continuing to be a part of our MGH family, despite the attraction of the golf course and the ski slope. And thanks to all the faculty, Dr. Hanel, Dr. Hausman, Dr. Roosh, and Dr. Orbe, and our local faculty, Neal, Kyle, Rohit, and Abhiram, for making this possible. It would not have been possible without our support staff, Megan Leelman and Chris Lee, who have so expertly navigated all the things in MGH to make this happen. And finally, to AO North America for giving us the template about how to run these webinars on Zoom. And I would be remiss if I did not finally finish up by thanking OrthoTV, who have increased our footprint across the globe by opening this up on 4 different platforms to viewers to either view in live stream session or as a recording. So with that being said, thank you very much. And Chris, if you are ready, we can stop the recording, but I would like to continue discussing some other things with Dr. Jupiter. Thank you, everyone. Have a wonderful day.
Dr. Mudgal, we would have to move to a separate session to continue discussion.
Hey, Jesse and Chai, thank you so much for inviting me. This is really enjoyable. Thank you.
Thank you.
Bye-bye.
Thank you. Chris, can you arrange that?
I'll send out a Zoom invite.
Thanks. Dr. J, don't go anywhere. You'll get a new Zoom invite. I need to talk to you for a couple of minutes.
So we log off this?
Yes.
Completely?
Yes.